Hello. Can you guys hear me? Good afternoon, everyone. We're finally going to get the program started. We just want to get the last few people in here and get everyone situated. But just wanted to say welcome. Thanks for being here with us this afternoon. My name's Courtney Collins. I'm the area director of the Illinois chapter of the American Foundation for Suicide Prevention. And I've probably emailed with most of you or met most of you. But again, thanks so much for being here. You know, the great thing about this program and why we like to offer it annually is not just the information you're getting, but this is also a way that we can let all of you, our supporters, know how your funds are being used. So whether it's through the walks or through general donations that you're making, we're able to put on this programming, and we're also able to fund researchers such as Dr. O'Connor in the work that they're doing to learn more about suicide and how we can prevent this leading cause of death. So just wanted to welcome you. I am going to pass it over to one of our board members, Meg Graff. She is going to do a quick introduction, and then we will kick off the program. So thanks again for being here. Thanks for all of your support, and hopefully you enjoy learning more about Dr. O'Connor's work.
I'm a little shorter than everyone else. Thank you so much for joining us today. The American Foundation for Suicide Prevention is the largest private funder of suicide prevention resource. This is very important because it results in current and effective education programs, reduces stigma, and leads to advocacy. The Research Connection program is one of my favorite days of the year because, like Courtney said, it tangibly shows you where your money goes. And we also, in Chicago, have the privilege of inviting a lot of students who can put this research to use. Today I'm honored to introduce Dr. O'Connor as he presents his research on helping patients transition from medically serious suicide attempts to healing. Dr. O'Connor has kindly flown in from the University of Louisville to be with us today. Please join me in giving him a warm welcome.
Okay, thanks. Okay, hi. Good afternoon. I'm happy to be here. Thank you so much. It's a real honor. Thank you, Courtney and Meg, for facilitating my visit. And thank you to the American Foundation for Suicide Prevention for supporting this work and everything that is done in the community. Thank you to everybody in the room for what you've done to help support the work of AFSP. And it's a real reciprocal process in that we each have a role that we play, and I think that, or we have multiple roles. I'm engaged in the walks, I'm engaged locally with what we're doing in Louisville, but I also wear this research hat and I wear a clinical hat, and I know that people in the room that you wear many different hats in terms of suicide prevention. But thank you very much for the role that you play. I just wanted to acknowledge that to begin. So I'm going to talk today about a line of research that I've been working on for the past decade, and it's really about helping people who have survived a recent suicide attempt and it was medically serious. And I'll tell you a little bit about how I became interested in that topic. Just as a disclosure statement, some current funding that I have, relevant past funding that helped support some of the research that I'll talk about today from the National Institutes of Health and from American Foundation for Suicide Prevention contracts. And then I do some training for CAMS Care, which is an evidence-based approach to treating, helping suicidal people. So I just wanted to let you know about that. So this is Vanderbilt University Medical Center. This is where I conducted the research study that was funded by AFSP that I'll tell you about. It's a very typical level 1 trauma center like you all have here. Level 1 trauma centers, people go to level 1 trauma centers if they need their lives saved. And there's about 4 different levels of trauma centers in the United States, level 1, 2, 3, and 4. If you are at a level 1 trauma center, it's because you need the highest level of care. But they're also a place where they serve the social safety net. So when I was at University of Washington, when I was a psychology intern to finish up my doctorate, I worked at their level 1 trauma center. It's called Harborview Medical Center. It's affiliated with the University of Washington. Harborview is a really interesting place. It's the only level 1 trauma center in Washington, Wyoming, Alaska, Montana, and Idaho. So people got flown in from all over, huge portions of the United States. And then it also served 10% monolingual, non-English speaking patients who came in too. So it's just a really rich place in terms of culture and medical needs and just great people that work there. So kind of my story a little bit, just to let you know how I got interested in this and in the field in general, is that when I graduated university, I joined the Jesuit Volunteer Corps, worked in a group home for people with schizophrenia for a year, fell in love with the clients that I served, and worked as a case manager for 3 years. And during that time, I also was a research assistant in Marsha Linehan's research lab. So I would go over there on the weekends and evenings and learn about dialectical behavior therapy, and totally inspired by the work that they did. She encouraged me to go work with Dave Jobs, Catholic University, so I did that. And when I was in training, I worked in all these places where people are at higher risk for suicide. Counseling centers, the VA, I worked in adult detention facility, a jail in Arlington County. I worked on a DBT team that served adolescents and adults for 2 years. So I really tried to immerse myself in that. So then when I went out to University of Washington for internship, the first rotation I had was on a psychiatry consult liaison service. So they serve a really interesting role because they're consulted by trauma docs or neurology, internal medicine, if there's a psychiatric need, like if somebody might be delirious, or which is not an uncommon thing when people have extensive surgeries. If there's a question about capacity to make a decision about whether or not to have a procedure. And what I discovered is that they're the first on the scene when someone has survived a very serious suicide attempt. So I'd worked in all these different places where I engaged suicidal people, and this one really blew me away. And I was not aware of really any research that was being done specific to this moment, and it's so powerful. And what I started to notice was that it seemed like people were in a different psychological headspace after they survived their suicide attempt, maybe than they had been in the weeks and months leading up to that. Just as an example, I met one gentleman who had written 30 suicide notes in 30 days leading up to his suicide attempt. And on that 30th day, he put them all in the mail and, made a very serious attempt with a single car accident. And his body was, severely traumatized. And when I met him, he was so happy he was alive. He was so thankful. And he had family and friends that rallied around him, but he was in a different headspace, and I wanted to learn more about that. And so that's what I did. So what's at stake? Just a little bit of information for you. In 2010, there were over 300,000 individuals hospitalized following self-directed violence. The majority of those are suicide attempts. And the annual combined cost for medical care and work loss is close to $10 billion. 2010 is the most recent data that we have from the CDC. I know it's a little bit outdated, but probably the numbers have gone up somewhat, but it's probably still a pretty good estimate. Suicide risk is 3 times more likely in the week after hospital discharge and continues to be elevated for years. And medically serious suicide attempts are associated with even more heightened risk of reattempt and mortality. There's a 19% reattempt within 6 months, 37% reattempt within 5 years, and 4% die by suicide at 18 months, 7% die by suicide across 5 years. If anybody in here is familiar with the Joint Commission, they're the people that credential hospitals and facilities. So they have put out a series of what they call sentinel event alerts that tell hospital administrators, you need to be doing these things if you want to maintain your credentialing. And they've actually raised the bar in terms of assessment and treatment of individuals who are suicidal on medical surgical floors. So that's a really exciting advancement. So what ends up happening if you have made a suicide attempt is that if you are requiring some medical services, you're transported to an acute care setting. At that point, there's an evaluation and disposition planning that happens in the emergency department. So you would be seen by a mental health clinician, and you would also be seen by more of a traditional emergency medicine doc. And if you're medically unstable, then you're going to be admitted to a medical surgical floor. That consists of the ICU, a surgical floor, or a medical floor. And when you're on those floors, your primary team is the docs who specialize in one of those areas. Okay, the psychiatry group is not going to be your primary service at that point. But what they're going to do is evaluate, and they're going to help decide what the disposition status is going to be. Should you return back to the community immediately? Does it make sense to go to an inpatient psychiatry setting? Or would it make more sense to go to, let's say, a rehabilitation facility if you have really extensive spinal cord damage, for instance? Eventually, everyone does make their way back out into the community and outpatient services. So what I discovered is that there's a real wasted opportunity when people are on medical surgical floors. What do folks do? Well, usually they'll have a one-on-one sitter who is not someone who's trained in mental health care, and really they're just to kind of observe, just sort of sitting and not really talking to you, kind of like you're being policed. It's used less often in these cases, but sometimes there is use of restraints. It's not going to be a 4-point restraint, it might be a 1-point restraint, but still that's a pretty traumatizing experience. And then people watch a lot of TV and they ruminate. People know what rumination is? You know, you're just kind of digging around inside your head, trying to figure some things out. Usually invokes a sad mood. So I think that, the medical community is really, number one, missing out on a great opportunity to try and engage folks after they've survived something that's so earth-shattering as a very serious suicide attempt. But I think we're also sort of failing patients when they're in the hospital too, because we're sort of, we're not engaging them optimally. And medical surgical floors and just general hospitals, they have a really bad track record of being negative towards suicidal individuals, taking out a lot of their own issues on the patients and kind of vilifying in a way. And so if you're thinking about, I've survived a suicide attempt, what does this mean as I'm trying to make sense of this and move forward? And if you're getting a lot of negative sort of expressed emotion from the medical staff, then that's going to add to sort of your shame and internalized trauma too, right? So this is all stuff that, it just has not really been dealt with to the degree that it needs to be, I think, in our healthcare system. So at Harborview, they pioneered the use of early intervention for people who come into the trauma center on medical surgical floors, because you might be asking yourself, well, can you really do much in that setting? And the answer is yes. There was a landmark study. If you were admitted to Harborview and you had drank some alcohol and then you sustained your injury, maybe it was a motor vehicle crash, maybe you fell and you bonked your head, or maybe you were injured by somebody else, but alcohol was involved. If a clinician came by and delivered 20 minutes of motivational interviewing, which is not an intervention and finger wagging, right? You need to stop drinking, but it's more about just sort of talking to someone about their goals and what role alcohol plays in their life and how maybe it contributed to this accident. If you do that for 20 minutes and you send them a follow-up letter on healthy drinking habits, you reduce the risk of re-injury by 50% across 1 year. That's it. That's all you got to do. 20 minutes, you deliver that, you reduce the risk of re-injury. It's kind of like leaving a pebble in someone's shoe. They can't take a step without feeling it. But it's more of their decision about what to do. So everybody stops drinking for about 6 months. Those people that receive that little brief touch, they continue to abstain from drinking alcohol. So that was pioneered at Harborview. And then when I was there as a faculty member, postdoc, I worked with a psychiatrist that was really focused on early intervention for people who come to medical surgical floors and they have really high PTSD symptoms because of what they've been through. So if you start that intervention on the medical surgical floor and you start by asking, of all the things that you're dealing with right now, what's the most concerning? You just treat them like a human being. Just ask them, what can I help you with right now? you start the engagement and then you follow up with people afterwards, we were able to reduce PTSD symptoms significantly with only about 2 hours total of intervention across 6 months. And I was the interventionist, and my colleague and friend was the psychiatrist who was prescribing the medication. So you can do this. You can start early after an accident, and then you can help people and change their recovery trajectory. So there are different ways that you can briefly intervene with someone following a suicide attempt. You can provide some psychoeducation, which was the basis of the intervention that was done by the World Health Organization supported study in 5 different countries that Fleischman and all did. They combined just some brief psychoeducation in the emergency department with follow-up contacts across a year, and they were able to reduce the risk of death by suicide. It's the only study that's ever been able to show that, along with, there's one other one that was a Caring Letters follow-up study for people who left an inpatient psychiatry unit and did not connect with outpatient mental health care. If they received caring contact letters for 3 years, it reduced their risk of death by suicide. Those are the only 2 studies that have ever been able to show in a randomized clinical trial a reduced risk of death. Okay, so those things, they can work. My colleague at the University of Rochester and the VA in Syracuse, Peter Britton, has developed a motivational interviewing approach to working with suicidal veterans. These are not attempt survivors. These are folks that are on the inpatient unit, and they're still kind of struggling and battling with very intense pulls and, being ambivalent about living and dying. So he applies MI principles to help people become more life-oriented. And then I bet everybody in here has heard of safety planning. Yeah? Is there anybody here who hasn't heard of safety planning? Nope, everybody's got this. Okay, so just a couple people. So I'll tell you what the old version of brief interventions look like. When I was a case manager, I would use a no suicide contract, and I would say, sign this that says that you won't kill yourself, and I'll see you tomorrow. Yep, it was just a CYA move. And it was also kind of shame, guilt-inducing, kind of like, you're giving me your word, don't lie to me, but I'm not giving you anything more helpful. So safety planning and crisis response planning are really the antidote to that, which is, let's do some contingency planning. Let's think about how to make your environment safe. Let's think about some short-term coping strategies that you can do internally. Who could you talk to externally? Where could you go if you needed help? And what are your warning signs that it seems like things are starting to get dark? That's totally different than a no-harm contract. So those have become ubiquitous in healthcare systems now, and they're part of any effective approach to helping someone not hurt themselves and stay out of the hospital, right, is having a good contingency plan. And that's what safety planning is. So those are some things that you could do. I tried to do just about all those on the medical surgical floor and a few other things when I was just trying to figure out how to best help people and figure out what they needed and what they wanted. And I took aspects of those and some other things to develop the approach that I came up with. There's one other approach that I wanted to tell you about that is really exciting. This is called the Attempted Suicide Short Intervention Program. It was developed by researchers in Europe, Conrad Michel, and it is for people who have survived a recent suicide attempt. It consists of 3 60 to 90-minute sessions. So it's relatively brief, but it's not something you could probably do on a medical surgical floor. Session 1 is a videotaped narrative where, let's say that I was the clinician and you were the patient. I would have you tell me your narrative about your attempt and your suicidality, and we would video record it. And then in session 2, we would watch sequences from that video recording and talk about in greater depth what you were discussing about your attempt. I would assign a homework worksheet, which is suicide is not a rational act. And then the therapist would complete a homework worksheet themselves of a case conceptualization. In session 3, you discuss the homework, collaboratively revise the conceptualization. So there's a lot of back and forth. Does this fit? Am I understanding you correctly? And then you create long-term goals, individual warning signs, and safety strategies. And people receive a crisis card. And then they also receive standardized letters, semi-standardized letters over 2 years. So that's a lot of different brief interventions wrapped up into one, right? Well, the data is amazing. I'm not sure if you all can read this, but over 24 months, there were 5 people who made a total of 5 attempts who received that 3-session intervention, compared to 16 people who made 41 suicide attempts in the condition that was receiving usual care, which is some counseling follow-up. So I just want you to know that there's really dedicated researchers out there that are doing really good work, and we're learning more about how to help people. And so like I play my role in the intervention work that I'm doing, but interventions like this and safety planning, they're really moving the needle about what we know can help people, okay? The thing about this is we don't know what part of it's the most important. But I don't know that that's something we should be concerned about if we're just really focused on saving lives. Let's go ahead and save lives now, and then we'll sort of try and go back and figure out what the most important pieces are later, right? So the ultimate goal is that we find this sweet spot where we maximize the population impact of our interventions. We want to create interventions that can be widely disseminated in an equitable fashion, not just for those people that have access, that they can afford private insurance, for instance. Provide the appropriate dose that will lead to significant improvements. Introduce new approaches that can be scaled up rapidly and maintained. I'm a psychologist. We're totally guilty of creating these really great interventions that work in a laboratory, and then you try and implement them in the real world and they just fall flat. So you got to come up with things that have ecological validity, that really can work within active systems of care. And then it has to match patient preferences, right? You really need to hear from folks that this is what they want to be doing. I was talking earlier today with someone about the work I do with group therapies for suicidal veterans. If you get a group of people together in a room and you do group therapy and you have them openly talk about suicide, a lot of people in our community would say that that's not the thing to do. And I lead a DBT group each week, and we don't talk about that openly, but that's a different kind of group. And these veterans at the Louisville VA, they advocated for the opportunity to talk openly about their suicidal experiences and to help each other recover. And it really works for them. So you've really got to understand what the patient preferences are, right? Otherwise, nobody's going to show up, and it's just about what you think is useful, but you miss their voice. And then you want to deliver an intervention that maps onto key aspects of a conceptual model. So when I started trying to figure out conceptually what's happening with folks after they survive a suicide attempt, I found this literature on teachable moments. So my intervention is called the Teachable Moment Brief Intervention. This is a behavioral medicine paradigm. So let's say that you have a child who has asthma and they have an asthma attack, and you go to the emergency department and the docs say, well, do you smoke? You say, well, yeah, I smoke. They say, well, the secondhand smoke is triggering your child's asthma attack. That's the type of cueing event that leads to rapid and sustained resolution not to smoke, right? If you recruit people from emergency departments in smoking cessation trials, even those who receive the placebo or no treatment at all, they still quit smoking at higher rates than if I recruited you just from the community, because there's a cueing event. It's a teachable moment. It's like, I think that that's what's happening after a suicide attempt as well. So in this case, the suicide attempt leads to increased emotion. People also do a better job of perceiving the risks associated with suicidal coping and making suicide attempts, and the benefits of coping in different ways. And then the self-concept and social role becomes much more defined. One veteran that I spoke with in my study at University of Washington had survived a self-inflicted gunshot wound to the chest. And he really felt like a burden to his family, and he felt that they would be better off if he was dead. That's why he shot himself. He described to me waking up, intubated, with family members looking down on him, with tears in their eyes, so thankful that he was alive. That was the moment that he knew that he had messed up. His self-concept and social role was really crystallized. He understood more deeply what it meant to be someone's son when his mom and dad are looking at him, or to be someone's cousin or brother, right, or uncle. So that, to me, is what I think is happening intrapersonally shortly after a suicide attempt, especially when they're very serious ones. So then we have to think about, well, what are proximal and distal protective factors that we want to enhance to try and improve the recovery trajectory as people sort of move forward after a suicide attempt? Well, the proximal protective factors, when I've talked with a lot of people with lived experience, a lot of people that I've worked with, and just working in that setting, of course, hope is number one. When I spoke with DeQuincy Lazine, do you all know him? Quicks? Yeah, so when I spoke with Quicks, I said, Quicks, what did you need to hear after your suicide attempt? He's like, I needed to hear that there was hope for the future. That's what was most important. So then flash back to what I was telling you about the way that clinicians and staff in medical surgical areas often engage people who have survived a suicide attempt to vilify, right? Quicks is saying people need hope. I agree, people do need hope. Enhancing reasons for living, and enhancing motivation to sort of move forward and work on your issues. I think those things are proximal protective factors because medications take a while to get to a therapeutic level. And it takes a while, honestly, to sort of learn new therapy skills and learn new ways of dealing with things like trauma and depression. So then the distal protective factors ultimately that are going to keep people alive, I would say, are really acquiring new skills, new ways of learning how to tolerate really strong emotions, and then enhancing a social connection. So not just joining a book club, but actually taking leadership in a book club, not just going to church, but actually really being a big member in that. Things like that. Really investing in social connections. That's what keeps people alive. So this teachable moment, brief intervention that I have developed really kind of comes from two larger evidence-based approaches. One is dialectical behavior therapy, and one is the collaborative assessment management of suicidality. So I just kind of distilled elements from those two evidence-based practices and put them into a 45-minute intervention that is meant to enhance care on medical surgical floors. So you really start by establishing rapport, breaking bread, just kind of asking somebody how they're feeling, physically, because they've been through a lot. Treat someone like a person first. When I've trained psychiatry residents, it's sort of like step out of the doctor role, kind of step into the human being role. I'm not trying to diss on docs, just like I think that a lot of times we just sort of get conditioned, especially in a very medicalized place like a hospital. And so when you're engaging somebody, really kind of start with the human first approach. And then you kind of transition into, okay, this is why we're going to talk about the suicide attempt, because basically we want to understand more about it so that we can maybe think about what you would need to engage in to prevent it from happening again. And I'm going to go into these in greater depth here in just a sec. So then you get into the real biggest elements of the intervention, where we try and understand what's directly underlying your suicidal ideation, not just about depression, not just about trauma, not just about substance use, because most people who have those issues do not in fact make suicide attempts. There's more to it than that, and I want to understand that from your perspective. Why a suicide attempt? We do a functional analysis about sort of what were the motivating factors for this attempt. It's kind of separate from asking someone why they're suicidal. And then we ask people about their relationship with the concept of suicide. And then we ask people about sort of what are the ramifications of the attempt, and then what could you take from this moving forward. We wrap up with some crisis management strategies, and we document factors to address further in care, either on the inpatient unit or an outpatient, and then we summarize and we wrap up. Okay? So let me just go into a little bit more description about what each of these things look like. I already went over what establishing rapport and kind of talking about the suicide focus and rationale looks like. But the way that we sort of transition to this is to say something like, I understand that things have gotten so hard lately that you recently made a suicide attempt. And I want to know more about what contributed to that. Let's take advantage of this moment, basically. So like my goal isn't to try and teach you new skills. I think a lot of consumers, a lot of patients they kind of get sick of this idea of they need more coping skills. It's just all about coping skills. This is a situation where we're trying to sort of witness and understand what happened, make sense of it, and why it happened, to prepare you to move forward. Okay. So when we try and identify these drivers of what's making people suicidal, a typical psychiatric interview, it tends to focus more on accounting of events that occurred in the hours or days just prior to the suicide attempt, as well as risk factors that are present. So it's more about kind of stratifying somebody on this risk spectrum and trying to put together a timeline. And it's not uncommon, like I said earlier, for folks to say, well, it's depression or it's alcohol use issues, things like that. What this part of this intervention is really meant to do is to help someone better understand, more specific to their experience and their unique factors, how they got to that suicide attempt. So for instance, one person I met in my study at University of Washington worked in the logging community out in Western Washington. And there was a big blow up in his house. He was married. It was his second marriage. And then he had a child in the home from the first marriage who was a teenager. Those two got into a big argument and they both left the house. And they really did not get along very well. So when they left, the person that I met went out to his garage and he tried to hang himself. And he was really lucky that his wife happened to come back home, and she discovered him in the garage, and she was on the shorter side. He was a really tall guy. She supported him with her weight while she called the police and the ambulance. They were able to save his life, and then they airlifted him to Harborview. So when I met him, I said, okay, so what happened? He said, Doc, I'm an alcoholic. I'm going to AA. I said, well, most people who have alcohol use issues do not try and hang themselves. So let's try and understand more about it. So over the course of the next 45 minutes, we walked through his perception of, like, he felt like the burden to his family. He felt like he was the piece that kind of maintained their suffering. And he hated that, and he felt hopeless that there could be any way forward. So when they left, he had decided that he was going to do them a favor and that he was going to try and take his life, right? So that level of discussion and walking through that with him is very different than the way he conceptualized it when he came in. And he's a really thoughtful person, really nice guy, but that's what he thought. He's like, my God, I'm an alcoholic. I need to take care of my alcohol issue. This is something that an alcoholic does. That's like his words and his narrative. And it was my job to sort of say, whoa. Let's understand that a little bit more deeply. So then when we did our 1-month interview with him in that study, he asked to speak with me. And he said, you know what? You saved my life. And I was like, well, what happened? He said, you convinced me that this did not have to just be my identity moving forward. Because he was really worried about how his community was going to look at him. Went back to this very small logging community in Western Washington. And that was a huge focus of what we talked about, which kind of goes to the second piece about relationship to suicide, right? And sort of like how he saw that. And he was in this state of mind where he really felt like this is something that might define him the way that other people looked at him. So we kind of talked about, what I think is that most people won't know what to think. They're probably going to be really surprised, because I bet you all don't talk about mental health a lot in your small logging community, am I right? And he's like, yes, absolutely. Okay, so it's going to be a lot about how you carry yourself, and the quicker that you get back into work, and the quicker that you take care of your business, that's how people are going to understand it and make sense of it. And that really worked for him, right? So we asked people, how would you describe your relationship with suicide? And it's a question that I don't think most people have ever been asked. But you get a lot of really interesting answers. And I tell you what, it's all about that person's experience. It's not about a diagnosis. It's not about a checklist or a screener, a symptom inventory. It's really about, so tell me about this. And, a lot of people have been suicidal for a long time. And this is something like they've worked hard to keep themselves alive. And I understand a lot of people in here understand this. But to really engage someone and talk to them about that in that way, when this is such a pivotal moment, I think that it's really healing for people. And I think that their guard is down as well. Like they're really interested and they're willing to kind of go there with you and discover this for themselves. So a lot of veterans now that I work with, I have a study where we're doing this brief intervention on the inpatient psychiatry unit at the Louisville VA. A lot of veterans I've talked to have a very negative view of suicide, and yet they made a suicide attempt. So the question is, how did that happen? How did you go from a negative relationship with that to one where you felt like this actually made sense for you? Because that's a real head spinner for the veteran who has done something that they feel like is very different than what they thought they would ever do, right? I just realized that I have an advancer, so that's really good. Some people have more entrenched forms of suicidality. One gentleman that I spoke to, part of our study as well, at University of Washington, he had made 5 suicide attempts in 6 months, and it was his 3rd time on the ICU during that time period. That's a person with a very entrenched level of suicidality. He was fully prepared to die, and he had made the decision that he was going to die. So my job was really just to sort of unpack that and say, so how did you develop that kind of relationship with death and dying? And we kind of walked through his history of being HIV positive in his early 20s and having to very appropriately deal with the prospect of a foreshortened mortality. He was actively engaged in his care, but then he became engaged in an abusive relationship, got depressed, he was ostracized by his family, and he started to hike around the Cascades and was just trying to figure out, what do I do? And he made a decision. He said it was like walking through a door. He decided that he was going to kill himself. And he resolved to do that. And what I said to him was, okay, I appreciate how thoughtful you've been about everything. The problem is that you've made these decisions in a vacuum, all by yourself. And therapists need therapists, Doctors need doctors. We all have our confirmation biases. So if you're looking for evidence to support what you already believe, you're probably going to find it. But if you talk with someone who knows a lot about this, they can offer some objectivity. And he liked that. He was like, well, yeah, this first time I actually thought about that maybe I went about this the wrong way. But here I've made 5 suicide attempts, so what am I going to do? It's like, well, you don't have to kill yourself. You don't have to make another attempt. There are some evidence-based treatments. We're in Seattle. There's something called DBT that's really, really effective. What do you think about that? It's like, well, yeah, okay, I'll give it a shot. It's like, okay. So it's a teachable moment. He was more open to that. We just had to figure out more about how he arrived in the hospital and talking to me, more about his story, right? We do a functional analysis where we ask people about the purpose, basically, of this attempt. A lot of times what you'll hear is to regain a sense of power, control, to unburden other people, to lessen their own psychological pain, or to communicate something to other folks. So we just try and do this in a very non-judgmental way, basically asking, why does it make sense that you made this attempt? What was the purpose behind this? And then we ask people what's been lost and gained. There are some serious ramifications. I know many people in here have been lost by the death of someone to suicide, and I'm sorry for your loss. For attempt survivors, I think it's also really important for them to understand sort of what's at stake here for them. Can really mess yourself up medically and physically. Loss of work income, concerns about losing jobs, impact on family, and lack of self-respect and reputation in the community. I mean, these are very real things that people experience after they've survived an attempt. And when we ask about what's been gained, we don't really say, what'd you get out of it? You know, it's really more about what can you take from this moving forward, right? And a lot of people will say, I actually feel more hopeful. I have a renewed sense of wanting to move forward with my life. We do some short-term crisis management strategies. This is not the main focus of the treatment, but if you're going to talk about all these issues, you probably should spend at least 5 minutes just saying, so what could you do to keep yourself safe as you're going to start moving forward with your recovery? So we do that and we document what those are. Try and use a variety of options that match onto different patient preferences: social outreach, physical activity, soothing, distracting, acceptance-based. And then we document the long-term strategies that need to be addressed in inpatient and outpatient care, and really emphasize the importance of engaging with outpatient services. And then we summarize and we wrap up. I realize that I am just now getting to the data, and this is a research connections, but I feel like I really wanted to give you a sense about what the intervention was. Okay, so now we'll get into the data. And it won't go too deep, but just kind of tell you where we are with this research and what we're going to do moving forward. So the first study that I published was based on that work at University of Washington. So I did a 2-year postdoc. I spent 6 months just hanging out on medical surgical floors with attempt survivors, kind of like a fly on the wall, just to kind of observe how do they engage with the psych team that's coming by. Psych team is often trying to talk about inpatient psychiatry. As a dispo, a lot of times people do not want to go to inpatient psychiatry. It's a real tug of war. And so I got to observe that. And it was interesting because I'd worked on that psych CL service previously, got to observe a lot of interactions between family and friends and just nurses coming in and different people. You talk to patients, kind of understand what were they looking for. And then the next 10 people refined the intervention, and then we randomized 30 to different conditions. Either receive that brief intervention, 45 minutes, or don't. We interviewed them on the inpatient medical surgical floor, and then 1 month later. So we had statistically significant improvements in people's motivation to change, to work on their problems in the brief intervention group. And then on people's reported reasons for living, these are reasons that people choose that they say they would not die by suicide. These are the most important reasons to them. In the usual care group, the trajectory, kind of the recovery trajectory, was about 50-50. So it's chance. Half the people got better, half didn't. Everybody that I talked to had a positive recovery trajectory, whether they were at the lower end, the middle end, or the higher end of reporting reasons for living. And I think that data, well, I know that data is what convinced AFSP to fund my study at Vanderbilt. So at Vanderbilt, I wasn't the interventionist. I actually trained a team of psychiatry residents and a social worker and a graduate student in counseling to deliver the intervention. And the main aims of the study were really to get all this pilot data and feasibility and acceptability data to say, is this just about me, or can other people do this? And can we do it in a different setting as well? And we get all that information, and then that allows us to really go after it with a huge grant, which is the one that we're pursuing now. So we were able to recruit 69 people from the medical surgical who had been seen on a medical surgical floor. Sometimes people come in on a Friday, and then they're already on inpatient psychiatry unit by Monday. If they had come through medical surgical floors, we still recruited them. I don't think there's nothing special about being on med-surg. I think it's more about the proximity to the attempt because it's still so salient. So we just didn't want to miss people, right? And so we continued to recruit people even if they had already gone to inpatient psychiatry, but we were able to recruit most people, 64%, directly off of medical surgical floors. We measured readiness to change, which is motivation, reasons for living, people's perceptions of being a burden or feeling disconnected. That's the interpersonal needs questionnaire. We asked them, how many outpatient sessions have you attended? And then we measured suicidal ideation and suicide attempts. We interviewed people in the hospital 1 month, 3 months, and 12 months later, okay? So in all, we had 66 people that were assigned to a treatment condition. 17 were training cases, because that was one of the major aims, was just to see, can I train these other clinicians to do this? They would provide the intervention, audio tape it, they would mail it up to my university, I would listen to it, I would code it for adherence, and then I would supervise them, okay? So I got to listen to all these cases, but I didn't actually treat anybody in this study. Interestingly, we had 53 people of the 184 where we attempted to recruit. We had 53 people who denied that they made an attempt, even though we knew that this was an attempt. Okay, and I think a lot of that's driven by, I don't want this in my medical record, I don't want anyone to know, and I definitely don't want to go to the inpatient psychiatry unit. So we did a different study on that I'll tell you about in just a sec. So all in all, people really liked it. 4 is the best, and all of our average ratings were above 3.5. People saying, did you get the service you needed? Did you like the quality? Did it help you deal more effectively with your problems? If seeking help again, would you come back to the service? Would you recommend it to a friend? That's a really good question. One person we talked to said, you know what? I didn't want to talk about this, but when I started to talk to the clinician in your study, I realized this is exactly what I needed to be doing. One person wanted to join our intervention team. He said, this is so meaningful to me. I want to come in here and talk to other attempt survivors at Vanderbilt and do the same thing. Because this just isn't happening. I mean, this is Vanderbilt. This is a fantastic medical center. But you know, no medical centers are immune to just sort of the standard way of dealing with attempt survivors on medical surgical floors. And from a training perspective, the residents felt like it was one of the most meaningful aspects of their 4-year residency. And the chief of the psychiatry liaison service said, not only are we training the clinicians to measure risk factors, but we're actually teaching them how they could affect some change as well. So it seemed like it was a win-win. This is very cheap, this is not expensive, people like it, and the care providers like it too. It's kind of the triple aim. This is the trajectory that I talked about earlier for alcohol use, just so that you can kind of see what these things look like, the brief intervention trajectory. At 6 months, everybody had stopped drinking. But those people who didn't receive the brief intervention, the 20 minutes, they went back to drinking. The people who received 20 minutes of motivational interviewing, they continued to abstain from drinking. And that's why they were admitted to the trauma center 50% less often. So our data kind of tell a similar story. We have basically everybody's looking the same at 1 month. And then between 1 and 3 months, that's when folks really, it seemed like there was a difference. And we were able to pick up these signals of statistical significance. They didn't completely get to that level of being significantly statistically significant. But again, we were underpowered, and that was not the primary focus. What you're looking for in a pilot study like this, I received a Young Investigator grant, is really some signal that, do people like it? Can you do the research? And does it seem like it's working? And our mechanism that we think is associated with reducing people's risk is to increase their motivation and reasons for living, to engage in some outpatient care. So what we found was that at 12 months, again, we had this signal where about 70% of the folks that we saw had engaged with an outpatient therapist versus only about 30% in the usual care group. And then that usual care group, about 70% had been rehospitalized between 3 and 12 months, compared to only about 30% of people in the brief intervention group. The reasons for living trajectory, it looks a little bit different than the others in that everybody looks the same between 1 and 3, but then our folks between 3 and 12 months reported much higher reasons for living compared to the folks who didn't receive that brief intervention. And then in terms of suicide attempts, even in a high-risk sample like this, suicide attempts are still not a high rate, they're still a low base rate behavior. So we had 2 people in the control group between 3 and 12 months who made a suicide attempt with full intent to die, one by medication and bleach poisoning and one by polypharmacy. Both of those people made repeated suicide attempts with ambivalent desires to be dead. We had one person in the brief intervention group who reported an ambivalent suicide attempt by insulin overdose. So when I talked to him at 12 months, after he had done the interview, he denied that it was a suicide attempt. It was the same thing that landed him in the hospital. It was kind of more about trying to impact his family dynamic. He didn't really intend to die. He was just, that was a way that he was kind of getting his needs met, and he was in a very dysfunctional family. So I'm not trying to shame him, but that's kind of a very different type of behavior versus when people are making full suicide attempts. So we didn't have anybody in the intervention group that was at that level. There was one person who did not receive the brief intervention but was randomized to receive it, but she discharged before we could see her, that made an ambivalent suicide attempt. So again, this is all preliminary data, but it signals that there might be something there. Based on the number of people who denied that they had made a suicide attempt, we abstracted the medical records for all of the patients admitted to Vanderbilt University Medical Center between 2012 and 2016 for a self-inflicted gunshot wound. And we wanted to see what proportion of those folks report that this was an accident, this was not an attempt. And these are all folks where we had really good collateral that this was most likely an attempt. We found that about 30% of people denied that their attempt was an attempt. And when that's the case, that group of people are significantly less likely to go to inpatient psychiatry. They're statistically more likely to go back home. And this is controlling for age, gender, engagement in mental health services, you name it. So that is what I would call an engagement breakdown. We're really missing a really good opportunity trying to engage folks just because there's a barrier there where they are not feeling like it makes sense to disclose that this was a suicide attempt for whatever reason. But we know that those people might be at elevated risk in the future, especially if they've made such a potentially lethal suicide attempt by surviving a self-inflicted gunshot wound. So the future directions, there are 2 active studies, one that I'm leading at the Robley Rex Medical Center, and then another that's a dissertation in Oklahoma at an inpatient psychiatry unit. And that one is really looking at kind of ischemia and mechanical pressure pain tests to see whether or not, by virtue of doing the intervention, does it actually decrease some pain tolerance, which would be a protective factor against future self-injury. We'd like to do a confirmatory efficacy trial, so that's what I'm pursuing now, to really test whether or not this really changes people's trajectories. And we've talked about a telehealth delivery option too, where instead of me needing to train a lot of people, we could all do it from a centralized kind of hub, and we could just have iPads, and people could talk to us for as long or as often as they wanted to while they were on medical surgical floors, and we could just kind of support them and help them recover and prepare for moving forward. So we're pretty excited about that, and the NIH is really excited about that as well. So this is what patient care looks like, patient-centered care on medical surgical floors, just sort of lost in between. And this is what patient-centered care looks like at Vanderbilt if you've survived a motor vehicle crash. This really nice person will come by, and she herself has survived a motor vehicle crash. She's going to talk to you about what to expect about what her recovery was like. I would love that to be the standard of care for attempt survivors on medical surgical floors. I think that is probably the way forward, honestly. You just got to be really thoughtful about not wanting to re-traumatize someone, and how to fully prepare them to kind of be in that space and take care of themselves as well. I'm almost done. I just want to let you know that this is a really alarming finding. When you do a research study, you learn all this new stuff that you had no idea about, like how many people are going to deny that their attempt was an attempt. It led to a different paper. This is a paper that I'm about to submit for publication. But look, let me just take a sip of water here. Look at how much people's perceived burdensomeness increases in the months after their suicide attempt. When I've spoken with people, especially like a reporter from the Huffington Post who's done a lot of good research or reporting on suicide attempts, he was blown away by this. He thought surely people would feel like more of a burden in the hospital shortly after the attempt, but that's not the case. And I think the reason for that is, one, it's the teachable moment. People are more hopeful, more engaged with reasons for living, and I also think that family really are able to kind of step up and support. And then a month or two later, everybody's got to go back to their life. And I think that the attempt survivor is still sort of trying to figure some things out. Maybe they're dealing with injuries sustained from the attempt. Maybe they're just trying to kind of get back into the swing of things. But I think this is a big reason why we see such high rates of death by suicide after inpatient psychiatry stays and after suicide attempts, is because initially people are often feeling thankful to be alive, but then sort of like we lose the capacity to really help them as they're sort of recovering and transitioning back to their lives. So that's inspired a study. I'll just skip over that, and I will just say that PTSD symptoms, I think, are a big piece of this, and our data that we're about to submit shows that really folks have really high rates of post-traumatic stress symptoms related to their attempt and their hospitalization 1 month later. And it's significantly associated with feeling like a burden and feeling disconnected from other people. So I'm working with a family scientist at University of Louisville to provide better aftercare. So we've recruited 10 people over the course of the last 9 months. It's a very small study. It's just me and a doctoral student who are doing the treatment. But we're seeing folks for 4 to 6 sessions after they've left the hospital, and we bring in a nominated family member into the therapy together. And we're really trying to help the families try and figure out how to move forward together. We try and focus on unintentional expressed emotion from family towards suicidal loved ones. There's a lot of unintentional criticism that gets transmitted that can maintain someone's feeling like a burden or feeling disconnected. So we're trying to help families better learn how to communicate in a way that is helpful, and also figure out where do they fit into the treatment plan moving forward. So they're really powerful sessions when we bring a family member in. It can be a parent, it can be a child, an adult child of somebody, it can be a brother or sister. It's just about trying to get the family a little bit more engaged. If you feel like a burden, it probably means that you have other people in your life, right? So we want to try and bring them in as well. So the conclusions, just be thoughtful about the ways that we try and help people with their recovery process. There are intervention strategies that can actually be really helpful. And then, what I'm pursuing now is, in what way do trauma and interpersonal factors impact that recovery trajectory? These are all the people that helped with this study. I received $82,000, a young investigator grant, which is a good amount of money, but all the people from Vanderbilt were free. They all donated their time. And the WKU study team consisted mostly of graduate students, and then the study mentors the DSMB, they were all just, they were volunteering their time. So, except for Kate, there is a small stipend for the study mentor as part of the Young Investigator grant that I had. So I want you to know that the money went a long way. I learned a lot from it, and it continues to sort of inspire me and help me figure out what type of research is needed out there. So thank you for the opportunity to come and present today, and I'm happy to take some questions if people would like to ask me anything. We have a microphone.
There you go. Oops. Oh, thank
And
you.
if people need to leave, because I know most people in here are probably working, then that's fine. I kind of went over a little bit. We're right at 1, so if you need to leave, no problem. Yes?
I was just wondering how, are other hospitals getting your information? Are they, is that going around, and are other people attempting to do some of the things you're doing?
Yes. By virtue of presenting at conferences, a lot of times you'll meet people who work in these academic medical settings, and they'll say, we really want to do that. So I send out my treatment manual to anybody who wants it. And I'll have a couple people per month that will email me, because this latest, the AFSP study just got published in a good journal. So I've had a lot more people that have been emailing me. If anybody emails me, I just basically send them the treatment manual, send them the adherence form, send them the articles, and just say, go ahead and do this. I was at Wake Forest last month, meeting with members of their surgical team that are the interventionists, and they're going to start doing this as well. So yes, I think people are starting to really think about this and trying to use this approach. Yeah, so thanks. Which is really gratifying, because, I mean, most research it gets done and then it goes on a bookshelf.
Yeah.
And then it doesn't get implemented. And it's heartbreaking for a researcher, because we put everything into it. We're really passionate about this. And it's painful when people don't use it. So I've been really thankful that people have shown interest and are using it.
That's good news.
Yeah, thanks.
I just wanted to know a little bit more about the patients involved in your study. Out of those 66 or 69 individuals, what was kind of a breakdown of age ranges? Did you also look at previous diagnosed versus undiagnosed mental health issues, and then comparative to substance abuse issues as well?
Yeah, we, as part of the randomization that we did, so basically we haven't looked at that, and I'll tell you why, is because, number one, we just published that study, so we want to go back and do some post hoc analyses. But as part of the randomization process, we match for sex, for history of suicide attempt, and for substance use issues. And so we're trying to make sure, because those are such important factors, and in such a small sample of just 70 people, that if that was weighted in a different direction, it could really impact, the outcomes that we had. So we have not looked at those things specifically, but now that we've published this, it just came out, we can go back and we can start digging around and learning more about who responds the best to something like this. Yeah, that's a really great question, though.
Thank you very much for your presentation. Dr. Connor, if I email you, would you be able to direct me to any resources? I am a retired educator, and I have been looking at statistics for the preteen group 10 to 13, junior high students, and the alarming rates of attempted suicides among this subgroup.
Yeah.
So this is something that is sort of close to my heart, and perhaps you may have some resources that could help me with PTAs and other parent groups, and try to influence principals and other administrators and school boards as well.
Absolutely. I can send that to you. My graduate school advisor, Dave Jobs, he's developed this therapy approach called CAMS, and CAMS is now being studied in younger populations like the one you're talking about. That group is virtually unstudied. And even for adolescents between 12 and 17, there's only one treatment now that has shown a significant reduction in suicide attempts, and that's DBT. And that study just came, I mean, that was just published this year. So that's the first one that we know works, right? So I can send you resources for younger kids as well that could be helpful. I think so much is about the family unit there, and the way that the family is able to understand and support their child. Bullying is such a huge issue, often associated with death by suicide. We had a 10-year-old boy that took his life in Louisville. What is it? It's April. I think that was back in January, and our community was really shaken by that. And he was severely bullied. He had medical issues, he had a colostomy bag, and he had just transitioned away from having that, and he was severely bullied because there was, just some issues around, his medical condition. And the research in that area that I've read shows that bullying is, of course, associated with suicidal ideation, but the child's perception of being a burden really moderates the intensity of how suicidal they're going to become. And so, again, I would say so much comes down to the family just openly communicating that the worst thing in the world to ever happen would be if we lost you. Nothing is ever too big of a burden. And really having those hard discussions with kids. And kids are trying to figure out what that all means as well. So I'm happy to send you the articles that I'm aware of. Yeah, and thank you for being here.
I just wanted to comment on the presentation. I think this was an excellent presentation, and I also think that the topic that you're presenting on and the research that you have done is very is needed. I just wanted to say that one of the things that, even as you were speaking about kind of like how you were working with medical students, one of the things, and kind of like the ideas that came to me is like, it would be great if we, coming from a public health standpoint, as like a public health worker, it'll be great if this information can get into the hands of those that are in medical schools, like the teachers and like administrators of medical schools, so that they can train them as the doctors are coming through school, so that they can know how to assist patients in these situations. Because as we know that there has been a rise in suicide attempts and successful suicides in the United States over like the last year. I've been hearing a lot of that in the news. So the medical schools are, as of now, to my knowledge, because I work with a few medical students, I supervise them, and they're not being trained in this area, or even in the area of, we talk about social services and public health, we talk about trauma-informed care. A lot of them are not being trained in that area, and so that's one of my passions, is like for doctors, even in their medical training, to not only learn about pushing medication, but for them to learn about what actually happened to those that they're working with, as to the reason why they are on these medications or need these medications. So this is excellent research. Well, thank you very much for that. I appreciate that. It means a lot. And I am in total agreement with you. So I'm, do work with our depression center. One of the initiatives that we have is to help the medical students learn how to do safety planning during their rotations on our inpatient psychiatry units. Most medical students are not going into psychiatry, but what we know is that most people who die by suicide have seen a doctor in the last 12 months. 90% have seen a doctor or specialist, and about 50% have seen a doctor in the last 4 weeks before their death. So what I think needs to happen is that every medical student really needs to learn how to sit down with somebody and do a really good safety plan. So that's a quality improvement initiative that we have on both of our inpatient units. And I'll tell you what we've done is that there's an attitudes towards suicide questionnaire that's 12 items long that we now give at the beginning of the rotation and the end of the rotation.
And I've run the data twice as we kind of get more medical students that go through. And there are significant improvements in attitudes towards suicide among those who have gone through this experience that includes the safety planning. Mm-hmm. And the two big items that really drive that, they feel like it's more rewarding to work with a suicidal person, and they feel more confident doing a thorough assessment around suicide. So that tells me that we really feel like we're onto something here. And I have a phone call tomorrow with the medical student education research group trying to figure out, can we get a grant to kind of do that in a larger way? And that's easy, and I'll tell you what, the medical students love it, because they don't want to just like go fetch patients and bring them back and then just kind of sit there. I mean, they're trained to be doctors. They are the most passionate, because they're so new to it. Yeah. And it is not hard to do a safety plan. So I'm happy to talk to you about that and send you all those things if you'd like to try and do that with some of your students. Mm-hmm. I think that it's a kind of low-hanging fruit. We could do it. And I think it's also maybe a Trojan horse around suicide prevention for docs as well, because a lot of docs are not going to go see a therapist or talk about their mental health issues. And if we put them in a position where they can develop empathy for a suicidal person and figure out this is how you help someone, this isn't so complicated. Mm-hmm. I think that might help them think about how they can help themselves too.
Yes, I agree.
Thank you so much for those comments.
Thank you.
Okay, we've got a question. We've got two questions.
Go here first.
Okay.
Sorry. Thanks.
I have just very quick question. Like the picture you had for the safety plan, is that an app?
That is an app.
What is it called?
Well, what does it say?
It's like
My
if you
3 app.
Google My 3, will it come up?
Yes.
Oh, okay. Oh, okay. Thank you.
Yeah, I couldn't remember that off the top of my head. Other great apps, there's a virtual Hope Box. Are people familiar with that? You know what a Hope Box is? Yeah, so Hope Box was created in Greg Brown's study around cognitive behavioral therapy for suicidal individuals, and they nailed it. It's an evidence-based approach. It reduced the likelihood of a suicide attempt across 18 months among people who were admitted to the emergency department after a suicide attempt in Philadelphia. They developed a Hope Box. It's like a shoe box, and you would put everything in it that reminds you of why you want to live. So I would have pictures of my daughter and memorabilia for my grandfather and all that kind of stuff in there. Well, the Department of Defense has created a virtual Hope Box, and you can put in your own songs, you can put in your own pictures, you can put in all of that information as well, and you can access that. So that's another helpful resource. The safety planning one is a really good one too. Yeah, thanks for your question.
Let me just do right here, and then we'll come over to the other side.
Okay.
If you think you might know someone who has attempted suicide that might be interested in coming into a facility to speak to someone who has recently attempted, how would they go about connecting with someone to be available for a program like that?
They would need to speak with the hospital administrators. There's probably a credentialing process that has to happen, a background check. And then I think that you would just, above and beyond that, I think that there would have to be a lot of support for that person as well, just to make sure they're in a good place for that.
But for them to start to even think about this, they would need to contact a local hospital to see if that hospital is even supportive of something like that? Or
And the larger hospitals have a psychiatry consult liaison service, so those might be the folks to reach out to first. But level 2, 3, and 4 trauma centers, they generally don't have a psych CL service. They might contract someone who would come by. In those cases, a hospital administrator would probably be the best person. Maybe talking with someone around the Joint Commission mandate, because that's a really low cost but potentially very effective way to deal with the Joint Commission's requirement that there's more done for suicidal people on medical surgical floors. Because of course I think a lot of hospitals see that and they're sort of like, we don't have the people like we're going
Well,
to have
that's
to
what I
staff
was wondering
up.
as I was watching, that pop up on the screen, how likely it is to have people available at that time, that you're going to have someone in the hospital
Yeah.
in those couple of days.
And so if
how
you
do you get people to sign up for that?
if you had a core of, 10 volunteers that were able to do that, I see, I know that some trauma clinic training kind of operates the same way, where let's say that if someone was assaulted, you would have been through all of this training
Right.
to help walk them through that, and you're on call to go to a hospital. I think you would probably have to develop something very similar to that, now that I'm kind of thinking that through a little bit more deeply.
Thank you.
Yeah, sure. Thank you. These are great questions.
Thank you, Dr. O'Connor, for your presentation. It's very insightful. I just want to know if you or any of your colleagues have done any research on law enforcement suicides or survivors of suicides, and if you know of any studies that have been done in the past or coming up.
I know that some people are looking at that. I know that I have not personally. I would be very interested in doing that. I know, I just met with a first responder firefighter this week, and that person was telling me about a National Center for Mental Health that's in Maryland for firefighters who have been traumatized because they see a lot of very traumatic things. I'm not sure if the same thing has been created for police, like you were mentioning. But if that was a resource, I think that would be a place for people to receive some services. At this point, I think people just know that law enforcement are at probably elevated risk compared to like the general population for a number of reasons. So I think there's a real need to really try and understand more how to help them for sure. But that's an area that we just don't know that much about. Just to put it into context, about 10 years ago, there were more studies, more clinical trials on arachnophobia than there were on suicide prevention. So we're really playing catch up, and we're becoming very aware of how unprepared we are and how much the lack of research that's been done. So hopefully in the future.
Thank you.
Yeah.
Thank you, Dr. O'Connor. I have a few quick